Welcome back from the break, everyone, and welcome to Topic's final session for the day, which will focus on emergency preparedness and is titled, Are We Prepared? Implementing a Public Health Emergency Preparedness Framework and Indicators with a Quality Improvement Lens. It's my pleasure to be here with you today for our conversation on public health emergency preparedness. Just a reminder about how this session will be conducted. In this session, we'll hear from 4 speakers, including myself, followed by a facilitated question and answer period. To ensure an optimal experience for all, we've disabled the Zoom chat and audio-video features for this session. For any technical issues, please email topic@oahpp.ca. For today's session, I'm thrilled to be with you today with members of our research collaboration to share experiences, insights, and knowledge. My name's Yasmin Khan, and I'm a physician and researcher at Public Health Ontario and the University of Toronto, and the principal investigator for this research. I'd like to take this opportunity to introduce our other speakers as well. May I first introduce Dr. Mark Lecision. Dr. Lecision works for Vancouver Coastal Health as Deputy Chief Medical Health Officer and Medical Health Officer for Vancouver. He is a specialist in public health and preventive medicine and a clinical associate professor at the University of British Columbia School of Population and Public Health. Next, we have Jessica Deming. Jessica Deming is a public health professional with over 16 years experience in the field. She holds an MSc in epidemiology and was an epidemiologist for 12 years at Region of Waterloo Public Health. Jessica joined Peel Public Health in 2023 in her current role, where she leads the Public Health Emergency Management Program. She also holds a social work degree and is passionate about equity, social justice, and well-being as integral elements of public health practice. And last, we have Dr. Madeline Law. Dr. Madeline Law is an implementation scientist, healthcare leader, and educational innovator focused on improving system performance. Dr. Law has spent 22 years in Brock University's Department of Health Sciences. She founded an initiative that partners with health organizations on quality improvement projects. She now serves as Director of Quality, Patient Safety, and Risk at Niagara Health, advancing learning health systems. Over the next 40 minutes or so, we'll share highlights from our research on public health emergency preparedness in Canada and aim to illustrate practically how a framework and indicators can help public health agencies measure readiness, set priorities, guide action, and drive quality improvement for future emergency preparedness in order to answer that question, are we prepared? As I begin my presentation, I'd like to acknowledge the funding source for this research program, CIHR. We're grateful for the funding which has allowed the organizations presenting today, ourselves along with our broader team across the country to advance research for public health emergency preparedness in Canada. So for my presentation, I'll be walking through how definitions and metrics for preparedness can support an understanding of if we are prepared for the next emergency and how can be used to inform improvement and how we've approached this with a research approach and with our research program. So in Canada and globally, we're seeing more frequent and complex public health emergencies. Infectious, we're seeing environmental, multiple kinds of environmental emergencies, as well as human-made. We know that public health work often remains in the background until an emergency arises. And once that urgency fades, we tend to get into the familiar boom and bust cycle of attention and investment or de-investment. Preparedness work becomes deprioritized exactly when long-term foundational work is most needed. In the face of more frequent emergencies, there has been limited evidence relevant to Canada's public health system to inform public health emergency preparedness practice. And across the country, we have a large and varied federation as it relates to public health emergency preparedness. Around 10 years ago, our research collaboration began working across academia and practice settings to address knowledge gaps for the field. And specifically, we wanted to have a focus on local regional public health agencies in Canada as the front line of the public health system where preparedness is operationalized. The two questions of are we prepared and how do we measure it were identified 10 years ago, long before COVID, highlighting that we didn't have a shared definition of what it means for the public health system to be prepared in the Canadian context, nor how to measure it to maintain momentum and demonstrate progress. So, our research program has worked steadily to answer these key questions of are we prepared and how can we measure it? In addressing the question of are we prepared and how to define that, we developed a framework for public health emergency preparedness that many of you may be familiar with by now, identifying 11 essential elements of public health emergency preparedness with ethics and values at the core. To address that second question, how do we measure it? We developed evidence-informed indicators corresponding with framework elements that are important to public health emergency preparedness practice and actionable at the local regional level. So together, the resilience framework and indicators give public health agencies tools to support answering these key questions and to inform an assessment and improvement of preparedness. The framework and indicators can support assessment and evaluation, but also guide prioritization processes key to resource allocation, planning, and improvement. More recently, our research program has been working towards translating this research into practice to have impact directly on public health in Canada. We've been working on the next stage of this research to understand more about how the framework and indicators can be used to support concrete preparedness actions and advance public health agencies' preparedness priorities, which we're sharing with you today. In studying implementation, we used implementation science and qualitative methods in working with 5 public health agencies across Canada to identify, implement, and evaluate strategies for enhancing public health emergency preparedness using the framework and indicators and applying a quality improvement lens. So I'd like now to highlight the first step we undertook as part of this study, identification of preparedness strategies. It's important to note that the landscape when we began the implementation study is important. The time at which organizations work together to identify their preparedness strategies using the framework and indicators was early 2023, as organizations had fairly recently wound down their COVID-19 response and were looking at recovery from the pandemic and towards preparedness for future. At that time, we asked public health agencies to use the framework and indicators to support a collaborative reflection process in their organizations on their assets or strengths, areas for improvement, feasibility considerations, and early ideas for tangible preparedness strategies. And what we found at this time of reflection post-pandemic and idea generation around the future was that public health agencies across Canada certainly had some similarities, with some differences in what they identified as their priorities using the framework. Top preparedness priorities among public health agencies were the elements of workforce capacity, planning process, and surveillance and monitoring. And I'll walk through those priorities at a high level, and we'll get more into those with our other presentations. In terms of the top preparedness priorities that we learned about from across the country in 5 public health agencies, 2 public health agencies identified that the workforce capacity element and indicators with the indicators within were their priority. with this element emphasizing developing and supporting staff in public health. The indicators of interest included those related to training, psychological and mental health supports, and team and skill building. Planning process was an element identified as a priority post-COVID as well, also by two agencies. Indicators of interest included those that could support incorporating learnings from response, considering ethical principles in planning, and ensuring plans and processes and relationships were developed and reflected a breadth of both infectious and non-infectious public health risks. Surveillance and monitoring was also identified as a priority through this study, with system-level data and insights being important to continue to progress since COVID as a preparedness strategy. So as I mentioned, we're going to get into more detail on preparedness strategies and projects in a moment. But just to highlight that this study aimed to reflect a process relevant to implementation and practice by which there is a concrete identification of priorities using the framework and indicators to inform those strategies. Those strategies, in turn, can support a process of adaptation, which can enhance system resilience. And so improvement we see as tying in into a process of adaptation that is inherent in a concept of system resilience, which we need in the face of public health emergencies, and that depending on an openness to change and building back better. Quality improvement was used as a lens for this implementation study. Preparedness priorities and corresponding strategies that were identified informed project aims, and existing resources for QI that are well adopted in other contexts, such as healthcare, were leveraged to support public health agencies in implementation. QI resources, along with QI approaches, such as a community of practice, serve to scaffold the implementation phase as public health agencies work towards advancing their priorities. So to wrap up my segment, we know that the frequency and intensity of emergencies is increasing, and that's a lot to strategize around. However, with increasing emergencies, we want to really avoid that boom and bust cycle and work towards enhanced preparedness as a system. Our goal is by having and using an evidence-informed framework, indicators, and existing improvement strategies that concrete evidence-based actions for public health agencies can be implemented. I'd like to acknowledge our broader research team for this research, and we're going to hear now about how the framework and indicators were used to develop preparedness strategies and projects used in practice, and some reflections on using quality improvement strategies to support preparedness work. And with that, I'm thrilled to turn it over to Dr. Mark Lecision.
All right, thanks so much, Yasmin. So I'm going to share some information about our project, which we called Enhancing Workforce Capacity for Public Health Emergency Management at Vancouver Coastal Health. So our aim statement was to improve workforce capacity for public health emergency management at Vancouver Coastal Health by assessing staff needs and developing training for all public health staff. And we are doing this hoping to improve the ability of VCH to respond to future complex public health emergencies. As Yasmin had described, we were engaging in this project just as we were coming out of the COVID pandemic. We had the experience that certain staff members who had had emergency management training were much more willing and able to kind of shift and reorient their work during the pandemic and respond to the needs that we were facing. Whereas the staff that didn't have this public health or this emergency management training were more resistant and found it very difficult. And so we thought maybe rather than just focusing on the staff who had already received emergency management training, we try to give a certain amount of emergency management training to all of our staff. So in terms of project activities, the first thing we did is we assembled Public Health Emergency Management Working Group. This involved staff from our 4 major program areas: prevention services, population health, and our surveillance unit, priority populations and outreach, and then health protection. We are also joined on this working group with our Health Emergency Management BC agency. They're a emergency management agency for health authorities in BC. So we formed that working group. We conducted a needs assessment to determine what the training needs of our staff were. We held an all-staff virtual town hall to deliver a certain amount of the information. We held a trauma and resilience webinar series to deliver a different part of the information, and then finally a set of virtual tabletop exercises. And I'll go through each of these. So, but first, the workforce capacity element. So that was the element that we selected, and here are the indicators that we chose to kind of implement. The first one we did was actually number 7. So the Public Health Agency conducts a needs assessment regularly to determine the emergency management training needs of its workers. So I don't know if we're implementing this regularly yet, but we did it once. And then the next one is number 4. The Public Health Agency has a workforce professional development plan for training its staff that is specific to emergency management topics. For example, content of emergency plans and protocols, incident management systems, communications. So we developed that training and conducted it. And then finally, the fifth indicator, the Public Health Agency workforce has demonstrated the ability to perform cooperative activities as an organization in the context of emergencies. This may be demonstrated, for instance, during exercises or activations. And so that's what led us to include the component of the virtual tabletop exercises. So in terms of the needs assessment, we had staff from each of the different program areas. So we developed a set of like a questionnaire that could be implemented either as an interview or as a focus group. And so each of the staff went back to their program area and either conducted a series of interviews or a focus group to kind of determine the emergency management training needs. And then I brought that to our senior management team of all the medical health officers and the executive directors and directors of our public health programs. And I did a focus group with that group as well. And these are the priority topics that emerged. So people felt it was important that everybody understood the structure and function of VCH Public Health within Vancouver Coastal Health, the role of Vancouver Coastal Health Public Health in emergency response, some background on emergency operations centers, incident command systems, emergency management structures in BC, how we work with local and regional governments during emergencies, existing emergency response plans, such as our pandemic plan and our seasonal readiness plans. There was kind of an idea that some more softer skills could also be developed through this training: communication skills, leadership skills, and then development of some kind of personal strategies. So personal emergency preparedness plans, how to combat burnout, stress, and how to develop resilience. And as we got these different priority topics, we felt some of them could be delivered better in different formats. So some of the kind of informational pieces, we thought, okay, we'll cover those in an all-staff town hall. The items about resilience, burnouts, and self-care, we thought that might be better in a webinar series for those that are most interested. And then finally, the kind of softer skills, communication, leadership, we would cover those in the virtual tabletop. So this is just an outline of what the all-staff town hall looked like. I won't read these topics again because they're essentially what was on that needs assessment list, but the different types of pieces of information that we wanted to convey. But we added a few other elements to this as well. We included staff testimonials of staff that had been involved in emergency responses, where they described kind of on one slide their involvement and what it meant to them and how rewarding it was, or what their experience was. They included a picture and we attributed to them. And so between each of these sections, we had these staff testimonials of staff who had responded to diverse kinds of emergencies, not just the pandemic, mpox, the flooding in Calgary, and different things, to just give people a sense that this can be really rewarding, responding to an emergency. And then we had a mentee element to this too, to ask people about their own experience with emergencies and how they feel about it, and so that we tried to make it interactive. The next part was this building resilience series. At the end of the pandemic, we had put aside a little bit of funds to do some recovery with staff. Basically, a lot of our staff were burned out. It was a difficult time, and so we put it aside this money. But as time goes on, you're busy. We actually didn't get to using it for recovery, so we decided to use it for prevention. And so we reoriented that money and engaged with this local person. He was a firefighter in BC who has experience with trauma and does seminars and teaching around this. And so we held 2 webinars that were open for all of our staff, and they were recorded, so if people couldn't get to the webinars. And the first one was really about the kind of personal impacts of the stress response. What is PTSD, and how do you protect yourself? How do you kind of develop resilience? So it was more at the individual. And then the second webinar was about teams and the system. And so what can teams do when they've faced stressful times together, things like critical incident debriefing and management, and then the role of organizations and teams in supporting each other during times of stress. So we did those 2 webinars. And then finally, a set of virtual tabletop exercises. This gave staff from all kinds of different program areas an opportunity to come together and to discuss some scenarios. We kept the scenarios pretty light to make them fun and accessible kind of to all levels of staff. We didn't want the staff with the emergency management training or the expertise to be the experts here, and the other people to feel like they didn't know how to contribute. So we kept the staff, the scenarios really kind of fun and engaging. The first one was called Godzilla Attacks, and this was a scenario meant to mimic sort of an earthquake scenario, but it was all about personal preparedness. How do you have that personal preparedness plan, a grab and go kit, what should be in it, and things like that. The next scenario was a zombie outbreak scenario. It was sort of modeled after a pandemic scenario, and this was about the importance of communication. How do you communicate, with your team during an emergency? How do you communicate externally during an emergency? What are the important aspects of that? And then the final scenario was called Alien Invasion, and this was sort of a mass gathering, kind of mass casualty event scenario. And the purpose of this was to kind of work on leadership skills, like what are the leadership skills that are needed by teams during public health emergencies. So in terms of successes and challenge, we held the all-staff town hall. We received tons of testimonials for people. People really wanted to share their experiences, and we tried to include as many of them as we could in the all-staff town hall. We leveraged those pandemic recovery funds for the webinar series, and we had lots of interest and good participation in the tabletop exercises. And in fact, there was interest in us doing these again, with new scenarios and things like that. Some challenges, we faced some logistical challenges as we did this. We realized we didn't have an all-staff email distribution list that was up to date. We had this fan-out process, and it was a bit clunky, and we realized that in an emergency, we really need that to be able to quickly communicate with all staff. It needs to be up to date. We had some problems with video and conferencing tools. Tools. We were in this phase of switching from Zoom to MS Teams, and anyways, so we dealt with that. And then finally, this was a research project, and we had trouble completing all the planned activities within the 9-month timeframe. But we did finish them all after. So we're proud. We had done the work, and we still completed the project. So now I will pass it over to Jessica.
Thanks, Mark. Good afternoon, everyone. It's good to be here. So I'm going to speak to some of our experiences at Peel Public Health on continuous improvement and emergency planning. So in early 2024, when this project with Yasmin's team and Public Health Ontario started, we were really at a point of recovering from COVID, and rebuilding the emergency management program after the COVID response. So all of our emergency plans at Peel, they were due for a refresh, and that made sense as one of the starting points for us where we could prioritize our focus, and we were able to leverage our involvement in this project to focus on applying a continuous improvement lens. So with that in mind, we focused on the planning process domain of the framework and specifically indicators 1 and 5. So we had a very ambitious aim statement with 4 parts. The first was to map out all of our existing emergency plans and then assess them for gaps. Second was to collaborate with an internal team of subject matter experts to update our key emergency plans by the end of 2025. So we did take our time frame past the project time frame. And third, it was to ensure that our people leaders and our staff had appropriate training by the end of 2025. And lastly, to conduct at least 2 exercises by the end of 2025, one with a communicable disease scenario and one with a non-communicable disease scenario. So to achieve those aims, we had 3 key activity areas. The first was to map our existing emergency plans and conduct a gaps analysis. Second was to update and expand or refine our public health emergency plans. And then third was to develop and implement a communication and training plan. So this was the initial result of our first activity, our current state mapping of our emergency plans. And this diagram shows our emergency plans in the context of other plans around ours within the region of Peel structure. So Peel Public Health is responsible for the plans in the teal color on the left in the red box. The other region of Peel plans are in blue, and ours, you can see ours are nested under the broader Peel Region Emergency Response Plan, and ours are also sitting beside other plans in health services. So one thing we could see was that some of our plans were based on organizational structure. So a division in Peel Public Health would have full ownership of a plan. So to ensure consistent processes, no matter what we were responding to, we've moved towards a model that would have ownership for all of the emergency plans with the whole public health unit. And that hazard-specific plans would become what we were calling function-based. So based not around organizational structure, but based around functions that are needed to respond to a given type of hazard. So that was the before picture, and this is the after picture of our plans mapping. So we went through several iterations of this structure as the work evolved, as our plans evolved, and as different pieces have been improved or our understanding was refined. So you may be able to tell the updates to our plans. We have the font highlighted in yellow where there were some changes. And we find we do refer to this visual often. It helps us and it helps others to see how all of the plans fit together. So to date, we were successful in updating 3 of the 4 emergency plans we had prioritized, starting with our all hazards plan, our emergency response plan. So at the end of 2024, we had updated that, and it included all the elements we were looking for to meet the gaps we had identified. So meeting elements in the Ontario Public Health Standard requirements and also best practice elements from the PHO framework. And we had validated that content with key internal partners. The second emergency plan that we renewed was the infectious disease urgent response plan. This was one that was adapted from an organizational structure-based to a function-based scope. So the development of this plan was led by one of our communicable diseases subject matter experts. And again, it went through several iterations. So the content was validated by an advisory group with a variety of subject matter expertise to ensure that we had perspectives taken into consideration from all who were likely to play a role in potential responses. So this plan was in a near final state when we actually had some lived experiences and we were able to test it out in several responses related to measles in early 2025. And then we were able to iterate again and incorporate some of those lessons learned from those lived experiences before the plan was totally finalized last year. So the third plan we updated was the Peel Region Drug Toxicity Urgent Response Plan. This is also a hazard-specific plan, and the scope was broadened. The original version was an opioid overdose plan, and then it was broadened to a more general drug toxicity plan. And the process to get to this updated plan, it was highly consultative. It was developed with input from a broad community network of over 70 partners in Peel Region. And this plan was also officially finalized as of last summer. So the fourth plan that we had identified as a priority was our Peel Region Pandemic Response Plan. The most recent version of this is for an influenza pandemic, and it's our intention to broaden the scope of that plan to be flexible for various pandemic scenarios. And then we paused this work actually to wait for the Ontario Provincial Pandemic Plan refresh to ensure that ours is in alignment. So we did note some key learning opportunities that we encountered in this work. I'll just say really briefly. So some of the challenges we encountered or learning opportunities were around the context just of how much it felt like there was to do in emergency preparedness work. The backlog of work that was put on a pause for several years, while all of the attention, we were in response mode. So all the attention was rightly focused on responding to COVID. And we had some general staff fatigue, a bit of staff turnover, and some loss of organizational knowledge, and those all, pose some challenges as we work through our updates. As for successes, I'll just highlight a couple from this slide. So we had full support from our public health leadership team to embark on these updates to our plans and spend some time building core capacity back for emergency management, not only for core emergency management staff, but also to revive our internal emergency management committee with representatives from different areas of the public health department. And also another success I'll just highlight, technology has been a huge win for us in emergency management. And we've been learning and improving in how we leverage the technology we have available to us, for example, SharePoint. So we've been using SharePoint sites to share emergency plans and resources internally with staff. And we've also been using SharePoint sites to house and manage all the documents for individual emergency responses as well. So this leveraging of technology that we have available to us is helping us to make things run more smoothly and to make processes clearer. And the work has continued. Last year, 2025, it's been a big year. We did quite a lot of staff training, making efforts to make emergency management information, the plans and resources accessible and top of mind for staff. Our main practice in 2025, we did intend to run at least 2 exercises, and our main practice was not from exercises, it was from lived experiences. So we had a number of responses last year, and that meant we did get to practice the plans both in communicable and non-communicable disease scenarios. And then I just want to acknowledge and thank the whole Peel Public Health project team, as well as the 3 lead authors of our emergency plans. So thanks so much. And I'm going to hand it over to Malin.
Excellent. Thank you so much, Jessica and Mark. There's really exciting to see all of the work that you've been able to engage in over the last really just 2 years in what you've achieved. So what I wanted to do now is just give a quick high-level summary of some of the things to take away from these presentations. And one of the pieces that I think is important for our audiences to consider is that this framework is big. There's lots of indicators. And how do you really decide on which one it is that you want to choose to make improvements? And I really appreciated what Mark and Jessica spoke about in terms of how they engaged people to actually decide on what those indicators were. It wasn't just the emergency management team that was like, I think this is a problem and went there. It was engaging leaders, engaging frontline staff, and really understanding which one of these indicators was a key one. And I know when we did this project with the teams, they had identified about 3 or 4 that were top priorities, but then they had to choose one for the project. And there were other topics such as, the idea of data, how we collaborate with our community. Those were also big top indicators for our organizations that were involved in the project. Just in thinking about Mark's project, I really appreciated from that quality improvement lens of the doing a real needs assessment related to the education and training. Because I know what we often do with training and education is say, okay, well, we'll put a module together and we'll put it out to staff and make everybody complete it sometime this year. As opposed to saying, okay, let's do a deep dive and really understand capacity, capabilities, how we can deliver each part of these pieces in terms of that training for emergency preparedness in a way that will be effective. So using the scenarios, which I love, as well as doing the town halls and all of those different pieces will be able to reach people in a better and different way. And then Jessica, to your work in terms of leading large projects in terms of your plans and recreating those, which is fabulous. So I did want to just open it up for probably two questions we can probably get in here in the time that we have left. So I'll first go to Mark. Can you tell us a little bit about some of the QI tools that you might have used throughout your project to really help advance your thinking about how you were going to bring about some of the changes that you did?
Well, I don't think I can list the tools, but I think what was important to me was just the QI approach. And so like, I think you could choose whatever tools you want, but because we were in this research project, it kind of forced us to use this QI approach. And I think it did make the project much more interactive with our staff. We were trying to train all staff, and this allowed us to get out there and actually hear what they wanted to have. And I think it did change the content of our activities. For instance, the kind of information or the desire for information on burnout and resilience and what teams can do, that really came from that engagement, and it wasn't really on our radar before that. So that led to a whole kind of different set of activities. And then also it kind of, I think, inspired us to do different types of activities too. We were a bit unsure whether we had the capacity to put on the tabletop, because we were looking around to see if there were existing scenarios that we could use for this that would really, and we really didn't come up with any that really were going to meet our needs. And so then I was like, oh my God, do we want to make these? But we heard during the needs assessment that staff really wanted to do this part. They really wanted to do the tabletop exercise, something where that was a bit more interactive and a bit more kind of like live or whatever. So that kind of forced us to do it and make the scenarios, and that ended up actually being the most fun part of this. And yeah, so so that the QI approach really kind of changed our project and the way we implemented it, I would say.
That's excellent. And I think related to that, I love the idea. I know scenarios are hard. I think it's a wicked opportunity for public health right now to be able to create and share simulation scenarios. I would see that as something I would love to do in the future. But when you do those tabletops and those scenarios for emergency planning, that's where we can also dive into the QI. So you actually go through it and you realize, oh, I don't know how I would respond here. How would we change this? What kind of policy are we missing, or protocols or understanding are we missing that we might need to integrate into our emergency planning as well? So it's almost using those as well as that QI approach. So I'll throw it over to you, Jessica. How about you?
Thanks, Madeline. Yeah, so I'll say there weren't specific quality improvement tools that we use, like explicitly used either. But can I say, I have my lean green belt and I'm a huge advocate. I think some of the tools are really fantastic, especially like if you find yourself stuck, right? Like if you're stuck, if you're having to deal with like a major barrier or a problem, like some of these tools can be so valuable to like take you out of your stuck place and help you move forward again. So I love some of these tools. I would say for this particular work, what we found most useful was the Plan, Do, Study, Act, the PDSA cycle, and having the structure of like that cycle and the project charter to help us prioritize our work and focus. But similar to what Mark was saying, I think what we found most beneficial was applying like a quality improvement mindset. It's applying that lens to your work. And particularly for us working on emergency plans, and it's a bit overwhelming having so many plans that need updates, and the context has shifted from pre-COVID to where we were finding ourselves. So particularly this idea of making incremental improvements iterating the versions of our plans and other resources. So it was really, formally or sometimes even informally going through that plan, do, study, act cycle multiple times. And when I just want to say too, thinking about, like I've thought about this with the PDSA cycle, I actually think that emergency management lends itself very well to quality improvement, a quality improvement approach, to making incremental improvements. I think they're compatible. So emergency management work operates on a cycle too. I think, probably lots of folks in the audience know that. So there's preparedness, there's response phase, there's recovery. So working in that emergency management cycle, and I think that emergency management cycle can very much reflect the plan, do, study, act cycle. So you plan your improvements, you do your improvements, you use them in your next lived experience, or you test them out in an exercise. You assess how that went, and then you go through it again.
Absolutely. I couldn't say it any better than that. I think you're also with your plans being all online and we have this ability to go in and iterate on those. It's not like something that has to stay static forever. If you go through an emergency or you have a new learning from something that's happened and did a tabletop and you realize, oh, we got to fix that plan. Let's go in there and do that. And so I think it's always just keeping that mindset with emergency preparedness of that continuous quality improvement. So I will hand it over to Yasmin. I know we're almost at time, and she'll provide us with some closing remarks.
Thanks so much. I'm just going to bring our discussion to a close. And so with that, I'd like to extend my sincere appreciation to our speakers today for joining us to share on our research collaboration, which has really been a team effort across the country with researchers and knowledge users. Such a team effort. And where we sit now, I mean, the importance of defining and measuring preparedness, from my perspective, has never been more important than where we are now, which is when that urgency of the public health risk recedes, and public health preparedness work shifts to the background with the examples that our speakers provided. And so what we have worked towards is having definitions and metrics that can support us in working towards continuous improvement, as sort of as like envisioning, very similar to how Jessica described, that emergency management and improvement can sort of like work together towards system level emergency preparedness for future public health risks. So for today, we hope that together we've highlighted for you how research-informed frameworks can inform preparedness priorities, guide effective action, and strengthen public health systems in anticipation of those future emergencies, and really help us answer that key question that always comes up: are we prepared?